Hello, this is Kim McAllister, and we are moving on to Chapter 37, Part 3. We're going to talk about the non-bronchodilating respiratory drugs. The first that we're going to talk about are kind of what I call the superhero of these drugs, leukotriene receptor antagonists. You may know this as Singulair. The generic is Montelukast. We'll also then talk about corticosteroids, and we'll talk about mast cell stabilizers. So leukotriene receptor agonists do not directly or indirectly in any way do any bronchodilating at all. And you may wonder, why does that help? Well, I will tell you, it's really great because it stops the ability of the body to continue releasing immune substances. Leukotrienes are substances that the body releases in response to an antigen, something maybe cat hair, or it could be grass or mold, anything that you are sensitive to. So when this happens, it starts a chemical reaction in the body where all of these mediators are released, and then mast cells degranulate, and you have inflammation, and the bronchioles constrict, and mucus is produced, histamines released, all of that happens. So the leukotriene receptor antagonists block that from being released. So leukotriene doesn't get released. And so what this will do then is help patients that have chronic problems not have as much problem. It stops the inflammation and it relieves the asthma symptoms. So these are medications that patients take ongoing. And it takes about a week before it begins to be effective, and then it helps. So by blocking the leukotrienes, it prevents the contraction of the bronchioles, it decreases the mucus secretions, it prevents vascular permeability. You may remember when we were discussing antihistamines that when all these mediators are released, that the blood vessels will dilate, and it allows fluid and proteins to leak out into the tissues. And this causes the swelling, the irritation, and the inflammation. It also causes the bronchioles to constrict. So when a patient takes a leukotriene inhibitor, it blocks this response. So this is for prophylaxis and long-term treatment of asthma, and it's given in children 12 and older. This is not something you would give somebody for an acute asthma attack because it's not going to do anything for it. Remember, this is not a bronchodilating drug. It's also used for patients who have allergic rhinitis, people who have chronic sinusitis also, it will help. Again, you want to tell patients this is not like Sudafed, not like a rapid-acting decongestant. They're not going to take it today and have relief today. It takes about a week before it starts helping, but it has a dramatic effect, and most people can tolerate it very well. So contraindications would be a known drug allergy. As always, you want to do a careful allergy assessment on patients. Any previous adverse drug reaction to it. It's important to also assess for the inactive ingredients in these medications, which is povidone, lactose, titanium dioxide, or cellulose derivatives. The adverse effects for Singulair are headache, nausea, and diarrhea. So they're fairly mild. Now we're going to move on to corticosteroids, also called glucocorticoids. And where are those released? Remember from our lecture in Med-Surg? That's right, the adrenal cortex. That's why they're called corticosteroids. Get the connection? They have anti-inflammatory properties, so they're going to reduce swelling and inflammation. They do not relieve the symptoms of an acute asthma attack. However, they do help albuterol and other beta-2 medications react better. They enhance the effect. They can be given IV. They can also be given orally or inhaled forms. And the inhaled forms reduce systemic effects. We already mentioned the fact with the nasal steroid sprays that they don't become systemic. The same is true if they're inhaled into the lungs. It may take several weeks before full effects are seen. So steroids work by stabilizing the membranes of cells that release those bronchoconstricting substances, as we just talked about with the leukotriene inhibitor medications or receptor antagonist. We talked about how all those mediators are released and they cause all of the problems. So this helps to stop those from happening. They increase the responsiveness of the bronchial smooth muscle to beta-adrenergic stimulation, as I just mentioned. And they have this dual effect of reducing inflammation and enhancing the activity of the medication. It also, we just talked about this, it also restores or increases the responsiveness of the bronchial smooth muscle to the beta-adrenergic receptor stimulation. So it makes albuterol work better. I think I'm going backwards. That's what's wrong. So an example of inhaled corticosteroids would be Beclovent or Arabent or Flovent. These are all examples. These are used for primary treatment of bronchial disorders such as asthma or COPD, and it helps to control the inflammatory responses that cause the disorder. It's used for asthma. It's also used with beta-adrenergic agonist. When patients are on a beta-adrenergic agonist, such as albuterol, they need to take that inhaler first. That helps to open up the airways, and then take the inhaled corticosteroid, because then it will penetrate deeper into the lung tissue. So usually patients are only given medication systemically if they're having an acute exacerbation or severe asthma, and they may be given oral or IV medication, or they may be given an injection. Contraindications for steroids would be drug allergy. It's not the sole therapy for an allergy attack. If patients have hypersensitivity to glucocorticoids, and patients who have candida organism or a systemic fungal infection, it's contraindicated. Also, think about the term glucocorticoid. What other problem do you think it might have an issue with? If you guess diabetes, you're right, because glucocorticoids can raise the blood glucose level. The inhaled corticosteroids can cause irritation because they dry out the mucosa. It can cause coughing, dry mouth. Patients need to use very careful oral hygiene. Oral fungal infections, and again, the systemic effects are lowered. Patients are more likely to have adverse reactions with the systemic corticosteroids. It causes problems with cyclosporine. Patients may need to adjust their anti-diabetic medication. It also causes a problem with phenytoin. And what is phenytoin? That's right, it's Dilantin, phenobarb, and rifampin. And remember, rifampin is used to treat tuberculosis. Phosphodiesterase 4 inhibitors are used to prevent the coughing and excess mucus from worsening and decrease frequency of life-threatening COPD exacerbations. Again, this is used in COPD, and it can cause side effects such as nausea, diarrhea, headache, insomnia, dizziness, weight loss, and psychiatric symptoms. Xolair is used to bind to the immunoglobulin E, which limits the release of mediators of the allergic response. Basically, when patients take Xolair consistently, it prevents IgE from doing much of anything. And this is given only by injection. Most patients have injections every other week for forever. And it does have an increased potential for producing anaphylaxis at any time. When patients begin therapy, they have to remain in the doctor's office for 2 hours. And then gradually they back that time down to 30 minutes. Patients have to be monitored very closely for hypersensitivity reactions, so they need very good education on what those signs and symptoms are and what to report. Patients have to let the doctor's office know before the injection if they're not feeling well. Medication takes a long time to mix and prepare, and it's extremely expensive and requires pre-authorization, and it may take a couple of months before a patient can get authorized to take it. Thank you very much, and we will move on to, part 4 of our presentation.